population. So before we start, just a few basic housekeeping bits. If you're having trouble hearing us, obviously check that your volume's turned up. And if you're using headphones, do make sure that they're plugged in. If you have any connection issues, you try another browser like Chrome or Firefox. And if you're really stuck, do send us an email on the address that's shown on that slide, tvscnsenate@gmail.com, and we'll try and help you. If all else fails, we are recording this and we will have it on our website, so you won't miss it. You can download it subsequently. During this webinar, we'd encourage you to write questions in the chat box, and do tell us who you are and where you're from so that our speakers can best direct their answers to you, and we'll pick them up at the end after the 3 presentations that we've got. So once again, welcome to everyone who's joined us today for this talk on health literacy. We know that self-care and self-management are a key for all patients, and particularly for us as patients when we need to choose appropriate treatments or manage our long-term conditions. But if we don't understand the instructions that we've been given or the options that have been offered to us, how empowered or effective can we be? Now, the statistics are pretty stark when it comes to the gap, a pretty wide gap, between the health literacy of the population and the way health information is provided to it. And of course, this is part of what the next 3 presentations will talk about, talking a little bit about the gap and what we can do, importantly, in trying to bridge it. So to discuss this and to share their findings and experiences with us, I'm very grateful to have our guests, Professor Joe Prothero, Jonathan Berry, and Mandy Warden-McLeish with us here today. So during this session, Professor Joe Prothero, who's a GP and a Professor of General Practice from Keele University, will be talking to us about the importance of literacy in a clinical context. She's also the chair of Health Literacy UK and is therefore well placed to advise us on this topic. Jonathan Berry is the personalisation specialist at NHS England, and he'll set the strategic overview as well as feedback on the work that's been done over the last 2 years. And then we'll move to Mandy Warden-McLeish from the Centre for Health Literacy Foundation, and she'll talk to us about what improvement would look like for practitioners, communities, and for us as individuals. We'll then take your questions through the online chat box forum, which we'll collate and direct to our speakers. So without further ado, I'd like to hand over to Professor Joe Prothero.
Thank you, Artie, for that introduction, and thank you for inviting all of us to speak to you about health literacy, what it is and why we think it's important. So, sorry, I'm just moving the closer box. Sorry about that. So, as Artie's just introduced me, I'm Joanne Prothero. I'm Professor of General Practice at Keele Medical School, NHS Clinical Advisor for Health Literacy, Chair of Health Literacy UK, but most importantly, a practicing GP. So what is health literacy? Let's talk about that first. Health literacy, according to the WHO, is the personal characteristics and social resources needed for individuals and communities to access, understand, appraise, and use information and services to make decisions about health. That's a really wordy definition, but the most important things I've highlighted there on the slide in green is that it's the balance between the personal characteristics and the social resources. And I'll come back to that later in the talk. But given that that's a really wordy definition, I'd just like to show you a very short clip that I think encapsulates what we're talking about much better than a definition. Sorry. Sorry about that, that's the wrong clip. Let's find the right one. Nope, that's the wrong clip. I'm sorry, we'll have to.
It's not just about the patient understanding what
Sorry about that, technical problem. We will have that clip available for you on the website later. Unfortunately, we've got the clips in the wrong order. So, moving on, I can't show you that clip, but it will be available for you afterwards. Health literacy. I've told you already that I'm a GP and a health academic, so obviously talking about health and its context, going to speak to somebody about my health or knowing where to go and seek help if I've got a, potentially broken my leg, or I've just got a tummy ache, or I've got a cold. I'm very comfortable with that, as I expect most of you in the audience are. But if I was to sit down with a financial advisor and start to talk about pensions and tax, I start to feel uncomfortable. It's not an area I know an awful lot about, and I don't understand it so well. And that's what it is about health literacy for some people, about trying to understand about their health. Health literacy affects patients' abilities to discuss health information or medical concerns with healthcare providers, to engage in self-care and disease management, to navigate their way through the healthcare system, act on medical-related information, adopt and maintain a healthy lifestyle. As I said at the start with the definition, health literacy is a balance between the skills of the patient and their family community and the environment in which they live, the health systems, education systems, social care systems, etc. One of the greatest problems we face in the health for our patients is the mismatch between what we expect from our individuals, our patients, our clients, in terms of what we give them in verbal information or in print or even in the built environment, and in the individual skills of our patients and families. The mismatch and the misbalance between those. So, for example, as a GP in Manchester, I often send patients for a chest x-ray to our local hospital, the Manchester Royal Infirmary. So I had this patient in my surgery who I particularly wanted to have a chest x-ray. I was quite worried about him. And the system for sending someone for a chest x-ray is to write out a form and give it to the patient and say to the patient, take this form with you to the Manchester Royal Infirmary, go to x-ray, and then come back and see me in a week's time and we'll discuss the results. The results will be sent straight to me. So we had a chat about it. The patient seemed very happy with the idea and the plan and went off with his form. I was looking out for the result because I was worried about his chest and I wasn't getting any results coming back to me from x-ray. So I was a bit puzzled. And when I saw the gentleman at his next appointment, I said to him, been looking out, the result hasn't come. I'm really surprised. They're normally quite good with the results. Did you have any problems with the x-ray? And he looked very embarrassed, looked at his feet, ummed a bit. And then he said that he went to x-ray, he went to the Manchester Royal Infirmary, but he couldn't find the x-ray department and he was too embarrassed to ask. And then you see the signs that we often have in our hospitals may not say x-ray, they may say radiology or something else. And that can be quite confusing for patients. So how big is the problem? Well, we know in the States that 35% of their population have basic or below basic skills and only 12% are proficient. We know that over 60% of Canadians don't have the necessary skills to manage their health, and a similar statistic in Australia. But what about England? Well, a colleague of mine, Jill Rowlands, and myself did a study published in the British Journal General Practice in 2015, where we examined the health information that we have out at the moment in England. We took a very broad view of health information, so this includes things like the instructions on the side of a bottle of Calpol, the instructions to fit a child's car seat in the back of the car, instructions on fecal occult blood screening tests that drop through people's mailbox regularly, instructions on the side of a bottle of bleach, safety instructions. We looked at those health information sources and we asked the experts who set the literacy and numeracy levels for our exam system, our education system, to examine the information for the complexity of the information on that health information. And then we compared that with the skills of our English working age population. And we were shocked to find out that on average, health information is too complex for 43% of people between the age of 16 and 65. 43%. And then if we include also that information that it includes any numbers, so for example, that bottle of Calpol with the dosing instructions on the side, that figure rises to 61%. So just to put that in perspective with some numbers around it, there are over 34 million adults in England of working age. And so this percentage means that between 15 and 21 million people of working age across our country may not be able to understand and use the information that we provide. They need to look after their health. Of course, there's a national and a regional picture, as you would expect, as for most things. So as you can see there, there are areas that have even worse figures than those up in the northeast and around the London area. And even in these, what look to be perhaps the more leafy green areas of England, even they have over 50% of their working age population that have difficulty with their health literacy. So low health literacy or poor health literacy is significantly associated with older age, poorer health, living in deprived areas, having a lack of access to the internet. Health literacy and illness, people with lower health literacy die earlier. They find it more difficult to take their medications as instructed. They're more likely to have one or more long-term health conditions. Long-term health conditions, when they have them, are more likely to be limiting, and they're less likely to engage with disease prevention, for example, cancer screening, immunisation. This is all from the research evidence. Evidence from the States, from the US health system, is that the additional costs of living with limited health literacy range from 3 to 5% of the total healthcare cost per year. Now, I realise that the US system has a very different health system to ours, but even so, even if there's a similar percentage point, then the additional costs in the UK may be between 3.5 billion to over 6 billion. We do know, even if those figures are less, we do know that lower health literacy is associated with higher use of A&E services, increased hospitalisation, more doctor visits, and fewer visits to other health professionals. So this concept of health literacy in this diagram here is something is the way that we see improving health literacy to link to improved clinical health outcomes. So if at the bottom left-hand corner we take account of patients' health literacy, their individual reading fluency, at the same time in the right-hand corner of having organisational practices sensitive to health literacy, then we would have tailored health and patient communication and education, and we'd have improved access to healthcare and productive interactions with healthcare professionals, both of which would lead to an enhanced capability for self-management and improved adherence and improved clinical outcomes. Right, I've just got another video clip that I hope will work. So see?
Yeah.
This, I hope, would be it's a light-hearted example of what we mean by health literacy.
Yeah.
Right, so I'm pleased that that video clip worked well.
Yeah, yeah.
Just on this slide.
Okay, sorry about that. It appears the video, we had some problems with the sound. So I'm pleased the video worked, and then sorry about the sound. So this is my last slide. Just in summary, health literacy, why does it matter? Well, we know that people with poor health literacy have worse health outcomes, more difficulty following medical advice and self-managing long-term conditions. People with long-term conditions report more difficulty understanding health information and actively engaging with healthcare providers. And of course, self-management requires active engagement of patients. And the effects of patient self-management programs are not equal for people with different levels of literacy. So I'd like to finish there and hand over to my colleague, Jonathan Berry from NHS England. Thank you.
Thank you very much indeed, Joe, for really setting the scene and context really well. I'm Jonathan Berry, and first of all, thank you to Artie and to all the colleagues here for inviting us to this event today. I'm the policy lead for health literacy for NHS England. What I hope to do today is build on some of the examples that Joe was talking about, and also just sort of set it in the sort of existing policy context. So, worth repeating the definition, I think, which Joe gave us. So, that's the WHO definition, and I think Joe touched on why it's important. I think I'll just go into a little bit more detail about that. I think what it really says, perhaps for the first time, which I think is really important for those of us who've been involved in a period of time now, is that it really explicitly recognises that there is an individual personal responsibility in terms of ensuring that you've got the skills, knowledge and confidence to be able to make those decisions about your health and your well-being, but also society, and in the context in which we're talking, the system, the NHS and the care system, also has to be a health literate system. It has to make it easy for people. So it's about how well we provide information, how well we establish services, and to think about the example that Joe gave, how well we signpost physically in buildings as well. So it's two sides. It's a two-sided coin, and really, if we're going to improve health literacy, we need to acknowledge both sides by working with both individuals and communities to ensure that their skills are as good as they can be, so we can support them to manage their health and well-being. But also, as a system, we need to ensure that the information and the services we are offering are designed to be as accessible as possible to everyone, including and especially people with lower levels of health literacy. And that second element is sometimes referred to as universal precautions, i.e. if we get it right for people with low levels of health literacy, we're probably going to get it right for everybody. There are three levels or tiers to health literacy, and the level that Jo was alluding to in her presentation very much around the functional health literacy, and that's actually ensuring that people just have enough in terms of basic skills, language literacy, numeracy, to be able to follow everyday health information and follow instructions. And then we move into some of the stuff that we're perhaps particularly interested in around this webinar today, and that's about interactive health literacy, and that's those more advanced health literacy skills, which we can use when we're actively making decisions about our health and our care, in changing circumstances, managing our long-term condition, self-caring for ourselves, and making decisions about what our preferred treatment options may be. And I think when you look at the figures that Jo gave us around the 43 and 61%, who are of course at tier 1, then I think we realise what a challenge it is to get people to this tier 2. And there is a third tier, and I suspect most around this webinar today are probably at this tier, and that's the critical tier, and that's services to address this. These definitions I think are pretty much recognised across the health literacy field. Don Nutbeam, who is a bit of an international expert in health literacy, devised them. And it's in fact Don who, when he was at the Department of Health, triggered much of the health literacy work that we're still doing today. Policy context. How can health literacy help us meet the challenges that the Department of Health has set for us at NHS England and for the system as a whole? Well, clearly, when you look at Joe's presentation and you see that actually health literacy has a huge impact on people living with health inequalities, and obviously if you improve people's health literacy, you can support that reduction of health inequality by actually ensuring that people have the information, functional information, i.e. they can understand it and they can apply it to everyday circumstances and take action on it. We can, if we're talking about tailoring information in the way that Joe described, that can then help meet the needs of people in an individual way by building a system that responds to their individual health literacy needs. So meeting those two objectives, and also give people the access to the information they need to make choices and shape their own care by making information that's responsive to their own health literacy skill level. So again, part of objective 2 for the Department of Health. It can support, and I'm sure, and Joe has clearly outlined that. I will hear a lot more about this in a moment from my colleague Mandy Warden-McLeish. It can support primary and secondary prevention by ensuring that information is functional for patients. It can also help improve co-production with patients by improving how we actually communicate with and reach out to those who are the hardest to reach, who are frequently those with the lowest level of health literacy. And of course, it can also support the better use of IT and digital services by ensuring that we also acknowledge that people have digital health literacy needs as well. So it meets quite a lot of the policy context objectives. In terms of our other big driver document, which is the next steps on the 5-year forward view, again, you've already seen from Joe's statement that people with higher levels of health literacy often use hospital services avoidably. So obviously, we improve people's health literacy, we can reduce that demand. We can also enable people to understand why it's important come forward and respond positive to invitations to various screening programs such as the cycle screening 1. We can also support the emerging accountable care systems with their core priority of enhancing patient activation, supporting self-management for long-term conditions, and improving prevention. And as again we see from some of the stats from Joe, again it will help us in reducing medication error. So we improve people's levels of health literacy. We can support all of those objectives within the next steps on the 5-year forward view. So, having done the looked at it from the policy perspective, what about the effect on people? Well, I think Joe's given some really good examples, so I won't dwell on these, but actually, you know, there is good evidence that says that actually you've got a lower level of health literacy, you're less likely to actually be able to control your type 2 diabetes efficiently and effectively. You're less likely to engage with preventative programs, and you will not just have increased mortality, but you will actually have worse outcomes as well, as Joe so eloquently demonstrated. What does this mean though in everyday real life examples? Well, for me, I think one of my light bulb moments around health literacy was when I spoke to a lady and she really didn't understand, she told me, why she wasn't getting any better, because the doctor told her that her cancer test was positive. And after some conversations with this lady, it became clear to me that she thought positive meant good. And of course, in everyday language, positive does mean good. And that's, I suppose, a really good example about health literacy. She understood she'd got cancer. She understood she had a test. She understood that it was a positive test, but she thought it was a good thing. So why wasn't she getting better? And of course, in everyday language, not in our weird health language, it does mean that. So actually, it's about all of us maybe actually understanding that people don't use health, don't speak the language of health that we do. Similar example of a lady who actually went right through her treatment and just simply didn't understand how her chemotherapy would actually work. She didn't understand why she was having it on a different side of the why the line was going in on a different side of the body to where her cancer would have been. And she thought that actually that would mean that the chemotherapy would be much, much less effective. And yes, she had been through the whole system and she had signed consent forms. There's still often failure to understand the link between what you eat and how you control your diabetes. An example from a previous role that I had was where people didn't actually understand that having cake and sweet things for like croissants and things for breakfast would actually have an impact on how they control their diabetes. I think the Hugh Laurie clip that Joe shows was stolen from my example, because I've actually had practitioners in an acute hospital in Derby reporting to me that had patients doing exactly that thing, actually spraying the inhaler on their throat, because they understood the words on your throat and therefore did it on their throat. And rather amusingly, but when you think about it in terms of what we're trying to achieve in terms of public health, we've had examples of people who think that the 5 supermarket-sized bags of fruit and vegetables is what they have to eat on a daily basis. And although that sounds quite amusing on one level, you can imagine the consequences of the individual who they try to keep to that diet for too long. So what have we at NHS England done? Well, in recent years, we've worked with a range of national strategic partners and local partners who are doing work at a health literacy work at a local level to set up a national collaborative which is guiding all of the work we do for health literacy. With the help of Joe's organisation and Mandy's organisation, we've actually set up a curated resource collection which is hosted on the UK Health Literacy Group's website, and that's trying to pull together all the resources, publications, policy documents, training resources, academic papers that we know about with regard to health literacy. And then finally, and we'll hear much more about this in a moment, ourselves, Public Health England and Health Education England supported a health literacy demonstration site in the East Midlands, and Mandy's organisation, the Community Health and Learning Foundation, were our delivery partner in that work. Without stealing Mandy's thunder, I'll just give you a brief overview of some of that activity. Well, why we did it? Well, we did it because of the statistics that Joe so eloquently outlined. We did it because there was already some existing work being led by Public Health England East Midlands. We did it because it's our existing commitment to do something. We wanted to test, and this is important to us, we did work and such as some of the awareness training for practitioners that Mandy's organisation had previously developed. So we wanted to test those rather than invent something new. And also because there are significant areas of health inequalities in the East Midlands. So very briefly, and Mandy will go into much more detail on this, what were the impacts of the activity? Well, for practitioners, I think there was some real light bulb moments, and perhaps the biggest one of all was that they had a better understanding of health literacy, the number of people with health literacy needs, and the tools that might be available to help them improve their communication with those people. And through this, some very early indications around improving patient experience, a change in health behaviours, and the ability to self-manage. And from the work we did in the community, some early indications that participants were better able to understand things like food labelling, portion sizes, sugar in food, and improve their approaches to self-care and self-management. And without any further ado, I'm now going to hand over to my colleague, Mandy Warden, who will tell you a lot more detail about the work in the East Midlands.
Seamless transition there. Hi.
I'm Mandy Walden-McLeish. I'm a specialist in public health by background with expertise in health inequalities, and I'm the Chief Exec of the Community Health and Learning Foundation. What I'm going to talk to you about in this session is the work we did in East Midlands to test some of the interventions that we provide and the impact of those interventions. I want to start by contextualising it. So we've mentioned the phrase long-term conditions a number of times today, and I thought it might be helpful to give you a feel for what that means in practice. We approximate it's 50% of all GP appointments, it's 64% of all outpatient appointments, and it's more than 70% of all inpatient bed days. Hopefully that gives you some idea of the impact that that has on the NHS. That's yours. I like this slide because it's a good visual representation of what we mean. So that midline is the expected level of need in the population. What you can see there on the left-hand side is those of us in the upper classes have a much lower level of need right across a number of health conditions and long-term conditions. If you go over to the right-hand side, there is a massively larger need once you go to the people with the lower levels of education, lower levels of income in terms of all of those health conditions. Put simply, they have worse health and they live less long. And those most need health literacy. So what do we do in the East Midlands to address this? My organisation works on that bottom-up, top-down approach that we've been referring to all the way through here. So we look to improve the health literacy of practitioners, the system, and by the system, yes, we focus on the NHS, but we also focus on fire services, social care, the voluntary sector. In fact, it looks very like the list of participants I had from James earlier today in this webinar. But we also work on the improving the health literacy of people in long-term conditions with communities and individuals. And most importantly, we look to evaluate the impact of what we do. So for us, so in the East Midlands programme, we looked at how we could strengthen the health and care system by delivering programmes that we've already developed and actually customising them to the clients that we were working with. So we delivered 15 health literacy aware training sessions to 239 staff across primary and secondary care, fire and rescue services, job centres, all of those people I suspect are sitting out there listening to this webinar. We also delivered, and that health literacy awareness programme is what we believe when it's delivered well gives people that light bulb moment. It helps them feel how it feels to be the people we're talking about. We also delivered 3 Royal Society of Public Health Level 1 Understanding Health Improvement qualifications to 57 staff. RSPH Level 1 in this case is a programme we've again customised, so it uses the National Skill for Health programme information to help the staff who are working directly with these people to be clear and confident about talking about lifestyle issues and about self-care and accessing services. I will get it the right way around, I promise you. So, the results of this work told us that 94% of the participants understood health literacy to be that their confidence was high or very high by the end of the course. The number of people who were confident about understanding it and using it was 14% at the start of this course. It was 94% by the end of the course. We know these are small numbers, but these are really big changes. 87% of the people we trained identified potential changes they would make to their practice because they'd attended the course, which is, of course, the point of the exercise. So what did they tell us about the course? They gained a better knowledge about the difficulties faced by the people they were serving. They said that attending the course had made them reconsider how low levels of health literacy impacted on the people that they worked with. So this has given me confidence to actually discuss these issues sensitively, allowing me to support people effectively. We'll come back to some of the techniques about how we help people do that in a moment. This course is so informative and interesting. I love all the games and activities. I've learned so much. I have to tell you that as a health professional for a scary number of years, loving things and activities don't always go with learning. It's nice if you can combine both. because we know it's the most effective thing. So what were the outcomes for these practitioners? They had, as Jonathan said, a greater understanding of health literacy and the impact of low literacy levels of health literacy on service users. Their knowledge and their confidence incorporating the practical approaches we taught as part of the session to enhance their service delivery to those with low levels of health literacy was improved. Their knowledge was improved about the services to which they could refer or signpost service users. And I know that doesn't necessarily sound intuitively like an outcome of this course. One of the things that we discovered was actually quite important in delivery was that a number of the programs we run are multidisciplinary and multi-agency. So not only did it give people an opportunity to learn about health literacy, it gave an opportunity to network and work with other people who could help them support the people with whom they worked. It also increased their knowledge across topics and their confidence in talking about them in the RSPH courses. We all think we know about physical activity or healthy eating or taking care of our mental health. But people who came on this course who thought that when they started came out feeling much more confident in knowing that they knew what the latest guidance said and how that might actually impact on the people they were working with. I just wanted to give you an example of one of the techniques that we teach in the courses. Normally when we do face-to-face courses, we get people to experience how it feels to have low health literacy, and then we do a series of sessions about their experience of it as practitioners, and then we move into what you can do about it and teach back as an example of a technique. So it's a way to make sure that a healthcare provider or social care provider or voluntary sector organisation explain their information clearly. It's not a test or a quiz of patients, as many of these people feel the whole health service to be. It might be asking a patient or a family member to explain in their own words what they need to know or do in a positive way. It's a way to check for understanding, and if needed, re-explain and check again. And it's a research-based health literacy intervention that promotes adherence, quality, and patient safety. Now we have an opportunity to see if the technology works. I'll stay away from the buttons, it's almost certainly safe.
It's not just about the patient understanding what is being said.
You may recognise at least one of the participants in this case.
It's not just about the patient understanding what is being said. Health professionals need to make sure what they are saying can be understood. There are a number of ways in which health professionals can help improve health literacy. First of all, there is the teach back technique. The importance of teach back is moving away from simply saying, "Do you understand?" The health professional should avoid asking questions such as, "Is that clear?" and "Have you understood everything?" because it is very easy for people to simply answer yes, and instead they should use questions such as, "To be sure that I've explained everything correctly, could you explain to me how you will take your medication? We discussed a lot today. Can you tell me what you found most important? So that I can be sure I've given you clear instructions, please show me how you will use your asthma inhaler at home."
Okay, so we've covered a lot in this short appointment this morning, so I just wanted to make sure that I've got everything across that I wanted to in this appointment and make sure that I've not missed anything out. So can you just tell me what it is you think that we've discussed this morning?
So I think you said about diet and exercise being important, and that also to see the practice nurse to get some more advice and get my feet checked. So I'm going to make an appointment with the practice nurse like on the way out.
You could use diagrams and charts to explain information. These are effective ways to visually represent important information and help patients better understand. Use simple language, avoid jargon. Information that might seem simple to a health professional might not be easy to understand if you are not used to the words, language and phrases being used. So keep it simple.
The technology worked. I trust you're all suitably impressed. Basically, it's about talking to clients or patients in a way that makes it easier for them to understand. We have colleagues in Stoke who use the term, it's okay to ask. I think we want it to be a stronger message than that. It's not just okay to ask, but actually we need to make sure that we have presented the information or asked the questions in a way that makes it accessible. So, okay, that's that one, I believe. Right, okay. So we've talked about the outcomes for practitioners, and so I just want to summarise for you the outcome of the work that we did for people themselves. So we worked with 56 people who had type 2 diabetes who were unable to manage it effectively and who had been identified as having low health literacy. So we ran a programme called Skills for Health, which is something that the Community Health and Learning Foundation developed in partnership with the Department of Health, NHS England, and which we continue to use. It's been very well evaluated and we know that it works. The programme looks both at developing people, giving people improving people's literacy and numeracy skills, but at the same time doing that through a health perspective. So it takes people through the kind of lifestyle or behaviour, healthy behaviours, healthy eating, etc., healthy eating for activity, but it also takes them through how to use services, self-care, etc. We tailored this programme specifically for this group of people, and that involved 24 hours of learning between 6 to 8 weeks. The sessions aim to examine the link. We wanted to examine the links between healthy lifestyles and behaviours and how that might impact on helping people to manage a long-term condition. So in terms of health behaviours, people on the course undertook a personal health self-assessment, so they understand where they were starting from. They made small pledges to positive lifestyle changes. They identified things they wanted to change to do better. We helped them to understand the Eat Well plate, portion sizes, understanding food labels. I'm sure many of you will appreciate how important the need to understand food labels if you're trying to manage type 2 diabetes. But I'm sure we're all very well aware of how complicated that is. We looked at hidden fats, salts and sugars, meal planning, hydration, and the impacts of smoking and alcohol, exercise and mental well-being in the context of their lives. We also talked them through and worked with them on how to access services and self-care, so they understood better who to go to for help and when and how. The programme increased participants' knowledge and competence in 4 key areas. So their ability to self-manage, to manage their condition independently, to access NHS services appropriately when needed, and to take their medication correctly. As an example, at the beginning of the course, 31% said thought they felt confident about taking their medication correctly. So that's less than a third of those people. Yeah? By the end of the course, that had increased to 69%. You can imagine that has a massive implication in terms of medication adherence and ability to manage your condition. I thought it might be helpful to finish with a case study from the little people. This is one of the people who was on the course. James has got a very physical job, eats large portions of food frequently throughout the day because he's got a physically active job. He's a little bit overweight. He wants to make sure that when he retires, which he's going to do shortly, that he improved his weight a bit better. He doesn't want ill health to impact on a happy and healthy retirement. He was struggling with a number of issues relating to diabetes, so his blood sugar was poor, his blood sugars were high. He felt generally unwell. He was constantly thirsty, and he suffered frequent headaches. His GP referred him to the Skill for Health programme we were running to help him to self-care more effectively without needing to rely on a lot of medication, which was something that James wanted to achieve. So what difference did it make? He loved the course. He found the fun, interactive style and topics very interesting. And he told us that that was one of the first times that he found education and learning a pleasure. He said the course had vastly improved his knowledge of portion sizes, hidden sugars, and how to interpret food labels. Using his new knowledge, he's taken steps to control hidden salt and sugar in his diet. So he's made some simple food swaps, regularly batch cooks and freezes. He told us the biggest shock was the portion size information, which he shared with his co-workers. As he said, I took the portion size handout to work and photocopied it for everyone. They couldn't believe it. In terms of health outcomes, he's reduced his blood sugar levels, he's lost half a stone, he feels much better, and is determined to continue implementing the healthy changes that he learned about. The work that we're doing is specifically aimed at doing both of these things. It's specifically aimed at helping us in the system, whichever part of it we're part of, in changing our practice, and it's aimed at helping individuals and communities to improve their health literacy so they're empowered to take action that can improve and protect their own health and lifestyle. I'll finish by leaving you some final words from people with low health literacy about what they would like from us. Don't put people on the spot. How often do we say, do you understand? Do you know what you need to do? That's actually quite aggressive and quite difficult to respond to with anything except yes or a nod, as in the video. We keep our forms simple and explain them. We could send them out before appointments so somebody who needs it can get help to do them. We can give oral explanations in simple terms, as you saw in the clip. We can use a variety of different media to share information. And we can make a simple, basic thing. We do not assume that people can read or write.
So I'd just like to say thank you very much to all our three speakers. You've got their names and their email addresses there, and they'd be delighted to take any questions or thoughts from you after today. I'd also like to thank our speakers for putting up with some of the technical glitches we've faced today, as well as all of you who are listening to have persevered through some of that. We're going to try and get Joe's video back up onto the screen. And while James is trying to do that, okay, look, we might be live here with the Nala video. Great, thank you, Bruce.
No idea what prognosis is.
Prognosis? I've never heard of prognosis.
Prognosis means the diagnosis or the outcome, I think. I'm not really sure now.
Chronic condition, isn't that when you have like a real chronic like pain, like severe condition?
Chronic condition. It's where something is severe.
Doctors and pharmacists use really, really confusing words. They're too long and big.
I went to a doctor to talk about my back pain. He said something about tendons and stuff ripped on my back, and I didn't know what he was talking about.
And had to pull up my own consultant recently for his lack of ability to explain in clear language, not infantile language because I have some intelligence, but clear language about what exactly they're on about. So I would say it's one of the biggest failings the profession have, both pharmacists and medical people.
Healthcare.
Great. Okay, so we're going to load some questions on that people have started to submit in. But before I do that, may I just take the liberty of asking you, it's such a fundamental aspect of health and social care as we go forward, and I sort of imagine that it's only going to get more important as we move into the sort of era of genomic medicine and the complexity that both health professionals and the public will need to grapple with. Do you have any thoughts on that?
I agree with you completely. I think it is getting a lot harder. We're already getting a lot harder because so much of our daily life is now online and, if you like, written. So, for example, choose to book. When you need to book an appointment to see a specialist, your GP has referred you to see a specialist at the hospital. These days you get sent a letter and a lot of text on what number you have to phone, and you have to give a password, and you have to. It's no longer as simple as it used to be, and there are lots of examples like that. And I think the world is getting more and more complicated, and very complicated things like genomics will be even harder. I completely agree with you.
Okay, thank you. So if we move on to question number 1. So thank you from our prevention and screening lead from Surrey Heath CCG, who's asked, what are the best mechanisms for checking back with the public that they have understood the health messages? So, for example, cervical screening uptake in women, perhaps who've had the HPV vaccine and they think they're protected and therefore don't need screening.
I think you saw in the webinar that the teach back technique is a really good way of doing that. What's perhaps most startling is the recognition that actually doing some of these things isn't difficult. You just need to know that you need to do it. So, for example, certainly we've had people who believe that they don't need cervical screening because they've only ever had one partner, so it's not particularly unusual. But I can see no reason why, when you're undertaking screening, as part of that process, you explain to the person that actually having the HPV vaccine does not mean that they don't need to continue with accessing screening services. But when you're doing that, it's up to the person doing that to be clear about saying to somebody, can I just ask, do you, when they've done that, to ask the person they're talking to tell them what they think, whether they think they still need to go for screening. Do they know when they last had their screening? It's part of a conversation.
I agree with Mandy. I'd also add that, of course, if we're actually developing messages about screening and indeed lots of other health issues, if we can actually co-produce those messages with members of the public who may well have lower levels of health literacy, that's, again, using that universal precautions approach, if we've co-produced with them, it is likely that we will have reached the vast majority of the population. So I would agree with Mandy, but I also say let's actually go back a little step further and actually start to think about how we can embed co-production, but co-production with people with lower levels of health literacy, and that is going out in communities where we would expect to find lower levels of health literacy.
I'd add to that and say that actually that's another part of the work that we do, and it can be extremely effective. We've worked with a number of national and local voluntary sector organisations as well as NHS colleagues to simplify information for people by simply going into communities and talking with groups of individuals about what they understand, what they want to know, and then going back and saying, does this rewrite work for you?
We can have our next question, James. Thank you. So how can we tailor health literacy approaches to a diverse population such as Slough, you know, where the issues of deprivation and educational, lower levels of educational attainment? I think you've covered some of that already in your talk, but could you perhaps describe it for different settings?
Certainly, when we Community Health and Learning Foundations is based in Loughborough and works in Leicester, so a very diverse population. And again, fundamentally, it is about working with those populations and those communities to understand their needs, to respond to them, and to check that you have met them when you're producing materials. What I would say is when we're delivering and developing health literacy awareness training, as part of that process, we do a piece of work with the groups we're working with to say, now you understand what health literacy means and how it's defined. Can you tell us how you've experienced it? And that inevitably means that you're getting the perspective of a person, whether they're from charities, voluntary sectors, whoever you're talking to has their own unique experience of how health literacy presents to them. And then we go on to talk about how are you going to change your practice. And again, that's a tailored response that people themselves are coming up with.
I think also to add to that, we would very much expect to see a personalised and person-centred care approach. So we actually put the individual's values, preferences at the heart of the conversation. And if we start to have that conversation in the black box of the consultation, to coin a phrase, then actually it becomes difficult not to tailor our approaches to the individuals who we're serving. But it's a chicken and egg situation. If we don't have that awareness of people's health literacy, and we think everybody's at that third highest tier of health literacy, it's difficult to do that tailoring. So yes, let's take a person-centered care approach, and let's have health literacy awareness sort of as one of the underpinning pillars of a person-centered care system.
I would only add one thing. If you're in a face-to-face consultation with any individual, obviously it's a really useful thing, and I'm sure most of you who deal with patients or clients, it's just to find as a starting point where the patient is at that moment in time, what they already understand, and then you can tailor your information to the level that they're starting from.
Thank you. Thank you. So our next question is, where does health literacy sit within the wider frame of patient activation, self-care and more specifically to patient education programs such as Daphne and Desmond, which I understand is for type 2 diabetes?
I think at the risk of sounding slightly repetitious, I'd actually say that patient activation, self-care, and self-management learning are all part of a person-centered care, personalised approach. So it clearly sits in there, but in a much more sort of specific way. I mean, for example, in many ways, patient activation and higher levels of health literacy is synonymous. So what you have with patient activation is you have the ability to measure somebody's level of patient activation, and then the question becomes, if you've measured somebody's level of patient activation and the measurement is at the lower end of the scale, then actually referring into a course such as the Skills for Health course, which is a national evidence-based health literacy resource, then you can actually improve somebody's activation, which I think was, fantastically exemplified by the case study that Mandy cited earlier. And I think one of the things also with many of the self-management learning interventions, what you often find is that they're pitched at a level that's way beyond the health literacy of many of the population, as we know, 43 and 61% struggle. So for me, actually, if we're starting to think about learning about self-management, we need to start thinking in terms of a spectrum and maybe a pathway where we would start by giving somebody a generalized health literacy intervention, and then move on once they've completed that to a more specific, condition-specific self-management program, such as Daphne, such as Desmond. I don't know whether Joe, you want to.
I would simply say, in answer to that question, where does health literacy sit within the wider frame of patient activation self-management? Just as Jonathan has said, really, but more simply put, that health literacy is key. It's the core. It's the basis. You need health literacy. You need to be able to understand what you're talking about in order to self-manage or in order to make a shared decision about your care.
Thank you. Okay, so if we have more questions, yes, there is. We understand from some there's a suggestion that the choice of treatments that might be offered, say for instance, for somebody who has a cancer diagnosis, might feel overwhelming for patients. So how can health professionals help move patients' levels of health literacy up the scale? And I assume they're talking about the tier 1, tier 2, tier 3 scales that was mentioned.
I think you have to take it in small steps. I think understanding where the patient is at. So what they already know about their diagnosis, what they already understand about their diagnosis, and what they understand about the treatments that are available. Once you've gathered what they understand, you can then build on. And it's really important not to overwhelm, as it says in the question, with lots and lots of information in one go. The beauty of general practice, for example, everybody says how it's terrible, our appointments are very short, but the beauty of general practice is they might be short, but they can be short at a very regular basis. So we can have a 10-minute consultation where we start a discussion, and then we can have another 10-minute conversation a week later, a few days later, where we continue the discussion. And I think it's really important to give people information at the level that they're ready for, and be ready to answer questions and offer lots of opportunity in lots of different ways, different medias, pictures, short films, to come back and answer the questions that the patient will inevitably have. Not rush them and not overwhelm them, and start at the level that they're at.
Thank you.
I also think you're absolutely right, Jim. I also think in some ways what we're talking about here is shared decision making, and at the core of shared decision making is spending time understanding the patient's circumstances, values, and preferences, and actually what their goals for their health may be, because their goals for their health may not to be have any treatment at all, might to be just sort of, I can't think of a better term than watchful waiting, for example. And I think that the other thing that we can actually start to think about is, when we're talking about sharing in decisions, some of the, Joe's right, we only have 10 minutes in a GP consultation, but we do have the opportunity to start thinking about how can we produce decision support resources that are health literate and appropriate for patients as well, so that they've actually got time to reflect on that before they come back for the second of those 10-minute appointments.
Thank you, Jonathan. So we've now started to get some more questions coming in, and there's one from Parvati Perman Howe, which says, "Are there any?" Sorry, John. Yeah, we're going to get the questions up onto the screen, but we'll keep going in the meantime. Are there any data to suggest whether health literacy is improving or declining in the UK?
I don't think there's any national data to suggest that, but I'm sure that Mandy can answer on local data and when health literacy is improving as a result of health literacy interventions.
Certainly the evidence is that when we provide health literacy interventions, whether it's the Skills for Health programs we're talking about, whether it's the health literacy awareness training we're delivering for professionals across the spectrum, those interventions have dramatic impacts on the confidence and knowledge of the individuals who are participating. What I think we're currently lacking is the ability to deliver those interventions and embed those interventions at scale and at pace. And that's the thing that we need to do next.
Thank you. So we've now got a question from Peter, which is, how is NHS England engaging with schools to improve health literacy, starting with children? And then also a question from Ira, similar, saying, are there any plans to introduce health literacy into education, especially in primary schools?
As you will have remembered from my presentation, we have a National Health Literacy Collaborative, and one of the partners around the table at that collaborative is the Department for Education. At the moment, the prime focus of the work has been on adults, but I know the Department of Education is starting to think about how some of the learning they're getting from their work with on the collaborative might start feeding through to the school years age.
Okay, so we have a question now about health literacy and libraries from Caroline. Are public libraries being encouraged to support health literacy? Public Health England is working with Health Education England, Chartered Institute for Library and Information Professionals, and the Society for Chief Librarians to deliver some workshops on finding good quality consumer health information, but it needs to be done on a wider scale. Also, workshops for the public would be useful. So I think the question is, are public libraries being encouraged to support health literacy?
I can answer about a local project that Public Health England in Stoke have been doing with their libraries and children. In fact, they've developed some dress-up boxes for preschool children. We found that reading and writing in our preschool children, or language, not reading and writing, beg your pardon, language in our preschool children was behind that expected as a national average. So Stoke-on-Trent Council and Public Health England in Stoke have been looking at interventions locally, and they've developed dress-up boxes in which they encourage children, along with their mums and their carers, to dress up in doctors' outfits, nurses' outfits, firemen's outfits, and role play health scenarios. So things like a visit to the hospital, or a visit to the doctor, or a visit to the dentist. And this increases the language of health in their vocabulary. And also, as a little side effect, it also increases the language of health in the parents' vocabulary. And that has had a difference in health literacy locally, but not at a wider scale just yet.
I do know, to follow on from that, Joe, that if I do forgive me if I get the acronym wrong here, but CILIP, which I think stands for the Chartered Institute of Librarians and Information Professionals, they are currently actively working on a health offer. They're working in partnership, as somebody I think quite rightly said, with both Health Education England and Public Health England to try and make that offer central. And we've been very supportive of that at NHS England as well, because we know that libraries are seen as trusted, safe and neutral spaces. And actually, when we piloted the national evidence-based health literacy course, Skilled for Health, we actually piloted it in among other places, 5 library settings across London. And in addition to all the other evidence that we know about the impact of that, it really came through that as a venue, libraries are a great place for learning about your health.
Make a comment as a part of our work as a voluntary sector organisation is working with community groups, and libraries and other community settings are a really good place to do health literacy, because people come to those because they're trusted spaces and because they're spaces where people come to have a conversation and a discussion, and so they're really good places to do health literacy work.
Thank you. So still in that same theme, there's a question now for Joe from Emily. Can people become members of a health literacy group? I'm a clinical librarian and would like to join. So we're building our community right here.
Yes, you can, Emily. We have a website and it's completely free to join. You just log on to our website, which is www.healthliteracy.org.uk. We'll make sure that the website URL is on the information at the end of this webinar, but it's free to join, and we run regular seminars. It also hosts the NHS England curated library resource. So definitely come and look at us, and please join. We very much welcome some clinical librarians.
Okay, that's brilliant. We've got another 4 or 5 minutes and 4 or 5 questions, so that's brilliant.
Loading up the questions, could I just say that one of the outcomes from or products actually, from the work in the East Midlands is that ourselves, with Mandy's organisation and Public Health England and Health Education England, are about to publish a how-to guide, which will include a number of different health literacy resources, including about how to simplify information, the content of health literacy awareness training, and some links to the Skilled for Health resources, as well as our evaluation report. They'll be published on the HEE website. We're just going through the very last moments of getting clearance for that. And we will, of course, let you, James, and you, Artie, know about that so that you can send that link out when it's live to as many people as require it from this webinar.
So we now got a question from Kate about English for speakers of other languages. Could you recommend any ESOL health literacy resources? So
I'm probably going to sound a bit like a broken record quite soon, but the Skilled for Health resources were actually mapped against various curriculums, because obviously we wanted to be clear that we were pitching it at the right level for people with lower levels of health literacy. So we also mapped it against the ESOL curriculum as well. So if you look at those resources, we'll also make sure that you get a link to that when this webinar is over. If you look at those resources, you will see where those links to the ESOL curriculum are.
And I think there are some sources in the curated collection, aren't there, on the website?
The Skilled for Health resources are on the Community Health and Learning Foundation's website. You can access them.
great. So rather than sounding like a cracked record, you're actually sounding like you've thought about all of this, pulled it all together, and there's a single repository for people. So that's great. Okay, so we've now got a question from Benita. Could there be a service offered at hospitals via NHS libraries or learning space specialist hubs?
I think there could be. We offer one in our area, in the Hayward Hospital in Stoke-on-Trent, where we have put a health literacy learning resource within a sort of a patient resource, so that patients that come out of this particular hospital has a lot of rheumatology clinics. Patients that come out with a diagnosis that they're uncertain about go specifically to this learning hub, and they ask for some help, and they're directed to various resources. So I think hospital libraries would be a brilliant place. Let's do more of that, definitely.
Great, thank you. Question from Caroline. How easy or difficult was it to recruit the 56 people who undertook the 6 to 8 week training, and how did you keep them engaged in the programme?
surprisingly, it wasn't particularly difficult. If you have type 2 diabetes and you're not managing it well, you don't feel well. And actually the opportunity to do something that's new and different that might help you manage that and put you back in control was a surprisingly popular option. And certainly for many of the people involved in that process, it was the first time that they'd actually had a positive learning experience that was grounded in practicalities and their lives.
Not specifically talking about that, but generally, I think we have to acknowledge that sometimes when you are dealing with people with lower levels of health literacy, who live in communities where there are low expectations, sometimes it's that engagement, that initial engagement is the most difficult part of the process. So what I often say to people is that actually sometimes we've in the sort of discourse around self-management learning and self-care and self-management, we've made it, you know, come and learn about how to manage your condition. And sometimes actually that's not the most important thing for people. Sometimes actually the most important thing for somebody is actually how to manage their money. So actually, if you can sell something around type 2 diabetes and say, you know, come and learn actually about how to eat more healthily and save a bit more money, and actually you might manage your diabetes a bit better at the same time, that's a lot more engaging than yet another come and learn how to manage your condition type approach. But it's about knowing that community, isn't it, and knowing what the best engagement methodology would be for the particular community that you're working with.
One thing I would say is that we do a lot of work with local communities, and not local communities but nationally. And Jonathan's absolutely right. It's about taking advantage of the things people want to know about and are interested in. So one of the reasons Skills for Health works is because grown-ups don't want to admit that they're not very good at literacy and numeracy, and they've often spent a lot of years being very good at not having to own up to it because they're very good at managing it. And what we know is that if you merge health with literacy and numeracy, it makes the outcome for both of those elements better. And so it's absolutely about going to groups that already exist, community organisations, community groups who are already meeting, who are already there for another reason. It gives you an opportunity to have the conversation.
Great, thank you. And so for our last question for today, we have a literacy versus health literacy question from Peter. Is there any correlation between general English literacy levels and health literacy?
Yes, there is a correlation. There's a strong correlation, but it isn't the whole story. This is my personal view, but it is backed up by a lot of research evidence, particularly around the areas of cognition and education levels. So individual skills, individual cognition, individual literacy levels are a part of health literacy. But added to that, it's also about your life experience of the health service that you're in. So it's not just your educational level. And when we do research studies and we look at the figures and we take into account education, it's a part of it, but it's not all of it.
An awful things. First of all, possibly it's, you know, numeracy is even more crucial. Can you just think how many numeracy transactions there are in a health context? 5 a day. How do we explain and communicate risk, which is one of the important underpinnings for all kinds of interventions, such as in shared decision making, for example, in percentage terms. And then the other thing I would say is that actually and health literacy isn't a fixed thing. If you've managed very, very, very well one long-term condition for a significant number of years, you're probably quite health literate in that. You probably understand what's being told you. If you then, as is increasingly the case with multiple comorbidities, then get diagnosed with a different long-term condition, your health literacy level absolutely drops right back down again. It's what's called, in educational terms, a spiky profile. So you can have your high spike managing, say, for example, your type 2 diabetes. You were then diagnosed with COPD. You have to start all over again. So it's, as Joe said right at the very beginning, it's context specific as well as life channel specific.
Okay, I think we'll probably wrap up there. We've just gone a little bit over our allotted time. Thank you all for staying with us, and apologies if we didn't get a chance to answer your questions on the webinar, but do drop one of our speakers an email if you still have a burning question for them. Thank you once again for joining us, and thank you to Joe, Jonathan and Mandy for this afternoon. Thank you.